Good. Hello, everyone. I'm Carolina Gorodetsky. I'm the medical director of the Brain Stimulation Program in the Hospital for Sick Children in Canada.
And hello, I'm George Ibrahim. I'm the surgical director of the clinic. So today we're going to talk to you about deep brain stimulation in pediatric populations. And this is what the surgery looks like. This is an implanted device with electrodes in the brain that connect to a battery that's also implanted that delivers electricity to specific targets to modify brain circuitry. And this is just a surgical view that shows that the electrodes are going in real time on the X-ray that you see in the back here. Deep brain stimulation is very well established in adult populations, but in pediatrics, it's actually much less common. In fact, there are almost 400 clinical trials in adult populations currently being performed. When you compare to what's being done for pediatric conditions, it's far, far fewer.
There are many indications for pediatric deep brain stimulation. There are indications that's much more studied, like movement disorders, and much more in epilepsy. But there's a lot of neurodevelopmental disorders that we're still trying to learn and understand what's the role of DBS in those conditions. So when we think about the different DBS targets in children, we can think about different groups. So the first group is different targets that involve the thalamus, and that can be used in individuals with different forms of epilepsy or forms of tics and Tourette's. We talk also about the group of the globus pallidus interna, the GPI, and this is the most studied target that's used in children with movement disorders, more specifically dystonia and chorea. And then we can use the nucleus accumbens as a target to treat individuals with obsessive compulsive disorders, as well as self-injurious disorders and other conditions. So we know that from studies that children with dystonia can develop a complication that's called status dystonicus. And we know that those children can be treated with DBS, and the DBS can be a life-saving condition, a life-saving treatment in those children. And we know that on top of that, those children can have an improvement in their dystonia more than their baseline. So what are the factors that can predict a good outcome for DBS in children? So first of all, we know that short duration of life with dystonia can be helpful, meaning that we want to intervene sooner as opposed to waiting longer. We know that genetic dystonias tend to respond much better than acquired dystonias, like, for example, cerebral palsy. The phenomenology of the dystonia is important. Mobile dystonia tend to respond much, much better compared to tonic dystonia. We also can look into distribution of the dystonia. So for example, involvement of the upper and lower extremities, as well as the trunk, is much more helpful compared to involvement of the speech and swallowing. And then we want to choose individuals that don't have fixed skeletal deformities or other neurological conditions, because those will not respond to deep brain stimulation.
So deep brain stimulation in children with dystonia is accessible through a humanitarian device exemption for children who are 7 years and older by the FDA, but it's also increasingly applied to children with epilepsy off-label. Now, there's several technologies that could potentially be considered for the treatment of children with pediatric drug-resistant epilepsy. And how do clinicians decide which intervention to choose over another? Well, it turns out there are about 6 or so factors that weigh in to those decisions. The first is access to the intervention. The second is the chance that the intervention will help. The third and fourth are the risks of major or minor complications. The fifth, which is very relevant for children, is the availability of evidence for that intervention. And then, of course, pragmatic considerations like the financial burden on family. Now, there are 2 important clinical trials that have been conducted for deep brain stimulation for epilepsy, targeting 2 different areas of the thalamus for 2 different populations of individuals with epilepsy. But I want to highlight that neither of those 2 studies included children. There is, however, emerging evidence that the use of deep brain stimulation, for instance, in conjunction to other neurotechnologies, if you don't see a benefit, can improve seizure control. In fact, this is a small study that was conducted, a partially randomized patient preference trial in pediatric populations that showed that the addition of deep brain stimulation to the treatment plan of children with drug-resistant epilepsy significantly improved seizure control 1 year after the intervention. And beyond seizure reduction, there was reduction in seizure severity, improvements in quality of life, and also in this study, a reduction in the number of school days that were missed by children.
Next, we want to touch briefly about the different neurodevelopmental disorders that can be potentially treated with deep brain stimulation. So we know that many neurodevelopmental disorders have a common brain networks that can be targeted with deep brain stimulation in order to improve the symptoms. And those include things like ADHD, anxiety, OCD, and others. So we want to concentrate on a group of individuals with self-injurious behavior in the context of profound autism. And we know that this phenomenon is not rare. And we know that those individuals largely can be divided into two large groups. So 80% of those individuals have socially mediated self-injurious behavior, meaning that this is a form of attention or escape from instructional demands. And usually those children tend to respond better to interventions like behavioral therapy or pharmacological interventions. But we also know that about 20% of those individuals have independent of social consequences self-injurious behavior, and it's divided into type 2, when those self-injurious behaviors are not sensitive to environmental manipulation, and type 3, when there's a presence of self-restraint. And this group of individuals do not tend to respond very well to pharmacological or behavioral interventions.
So although the neural circuitry of most neurodevelopmental disorders is incompletely understood, we can leverage some of what we do understand to develop treatments for children that are severely affected, that have diminished quality of life. And as an example, we published a clinical trial, a phase 1 clinical trial that obviously underwent many layers of regulatory and ethical oversight of deep brain stimulation targeting the nucleus accumbens in children with severe self-injurious behaviors. In 6 children, we reported that there were no serious adverse events and that this was a feasible intervention.
We also looked in these individuals into the clinical improvement, and more specifically, we applied different tools looking into the self-injurious behavior improvement, and we did demonstrate that those individuals experienced reductions of the self-injury, as well as the improvement of their quality of life after 1 year of treatment.
So we've demonstrated that deep brain stimulation is a very valuable tool for children with movement disorders. It's used increasingly off-label in children with epilepsy, and it has a role in very carefully selected investigational populations with neurodevelopmental disorders that needs to be investigated further through carefully designed clinical trials.
It's extremely important when you think about treating children with deep brain stimulation to put it into ethical framework. And it's really important that this type of studies are done in very collaborative way when many stakeholders can give an input around the treatment of this very complex children. So really, just to summarize what we're talking about, we know that there is a lot of potential implication of deep brain stimulation. We have evidence for dystonia, but less for epilepsy. And there's an emerging evidence that potentially some of the neurodevelopmental conditions can be treated with deep brain stimulation. We briefly touched on the many challenges that deep brain stimulation in pediatric conditions has, including some of the technical difficulties. Children are definitely smaller than adults. We did discuss a little bit the ethical importance and the fact that there's really limited data around using deep brain stimulation in pediatric population. as a future direction, there's really an urgent need to establish more biomarkers that can give us more information about the objective improvement of those individuals. We are hopeful that at some point there will be an adaptive stimulation in the same way that's now used more commonly in individuals with Parkinson's disease, and really emphasize the need of multi-site collaboration in order to move this field forward and to improve the quality of life of these very complex individuals.
Thank you very much for joining us.